Good evening and welcome. I'm Chris Parnell.
Reporting from Moscow.
Tbilisi.
Times Square.
May your dreams be your only boundaries in life.
Hello and welcome to Living Well. I'm William Kenley. The largest generation of Americans born in our country's history was the baby boomers. Data from the U.S. Census Bureau shows that there are nearly 77 million baby boomers living in the U.S. today. As baby boomers age, there is a growing need for retirement homes and communities. Ron Ruckland, Executive Director at the Village of Germantown, is here with us today to tell us more about the types of retirement communities that allow residents to age in place. Ron, thank you for being with us today.
Thank you. It's my pleasure.
What is a continuing care community, Ron?
Well, there are really several dimensions to what continuing care means. At a simplest level, continuing care means when somebody comes into one of our independent living apartments or villas, that whatever health care they may need, with the exception of acute care in the hospital, they can receive on our same campus by the staff that's been with them and provided them service in the independent level. So whether it be skilled nursing or memory care or assisted living, they can get that in the same campus. But there really is more to it than that, because they could go to a skilled nursing facility or an assisted living facility independently run down the street. But I think the advantage that the residents who choose to live in a continuing care community is they want the security of knowing that the standard of care and services they receive in the healthcare section are consistent with what they received when they were in independent living, and that's provided by the same people that they knew and trust and can ask questions of, and if they have concerns, they can get them dealt with. So that, along with the fact that spouses can see their loved ones on the same campus, friends can come over, and they can continue to participate in everything in independent living while they're a healthcare resident. So that's kind of the, in the larger sense, what continuing care means. I
see. So there are lots of benefits. Are there other benefits to aging in place that you'd like to point out?
I think on the independent side, we have inpatient care that we just talked about, but because of the relationship, largely because of the relationship with Methodist that we have, we've got an inpatient or a clinic, a wellness clinic for our independent living residents, and we have physicians there 3 days a week. We have a nurse practitioner the other 2 days a week, and we have a nursing staff that's dedicated just to wellness programming for our independent living residents, providing education, therapy services, and just questions and answers, and getting our residents in touch with the right provider and the right services they may need. So the benefit of that is we try to provide services that keep our residents independent. We do strength and balance testing to try to eliminate or at least reduce the number of falls, which is one of the largest reasons that residents have to have inpatient care. So those are some of the things that I think are really a benefit.
It sounds certainly like it. Are there certain or special amenities that the Village at Germantown offers to the residents?
Well, it's pretty much a little community or a little town on one campus under one roof. We've got 3 different dining venues. They can eat in the formal dining room, the Monarch dining room with waiter and waitress services. They can go to the bistro and eat, which is much more casual, but it offers all kinds of entrees, sandwiches, soups and salads and so on, and they can be more casual. Or they can eat in our bar, and we happen to have a full liquor license, and we have a bar with a bar menu. So if you enjoyed wings when you were outside in the community, you can come to the village and have the same kind of experience. You have a beautiful indoor pool, walking track, exercise area. We have on staff a full-time exercise therapist that works with our residents. We have professional entertainment 3 or 4 nights a week in our auditorium. That's all broadcast on our in-house TV service as well. So if residents want to stay in their apartments, if they want to come down and join us. The thing about the village is it's a resident-driven organization. You know, we don't create a package and say, now you have to fit into it. It's their home, not ours. So the programming that we have, the food that we serve, the priorities that they have are the priorities we have. So the village really reflects the culture of the people that are living there.
Are there some special things that have grown out of what the residents or the owners want?
I think one of the things that's just given me so much pleasure is to see how generous our residents are and how they continue to contribute to the larger Germantown community. They volunteer in schools. They have donated to so many charities. The Make-A-Wish Foundation, they've given several trips to children. Some of the schools down in the downtown area that need assistance, the Binghamton School, they've done fundraisers and collected tens of thousands of dollars for charities and programs throughout the community, and they're actively involved in volunteer programs all over the community. They're just a great group of people that they haven't just retired to say what's in it for me. They continue to give, and it's just a blessing for all of us to be around them.
That's great. That's great. Well, I understand that you're expanding right now. What's the expansion include?
Well, we're building right now under construction a new assisted living building, and it's a 3-story building, and the top 2 floors will be assisted living apartments, and the bottom floor will be memory care and a daycare center for our residents, primarily with dementia as a primary diagnosis, but non-dementia people can use it too. And it's not just that we're adding capacity, but we're trying to create more state-of-the-art living spaces. These are apartments as opposed to the alcove units that traditionally have been associated with assisted living. Beautiful common spaces, 24-hour-a-day dining, so that when residents want to eat, they can. And if they're really hungry and they want a hot dog at 8 o'clock at night, the staff will be able to do that. We've got the systems in place and the equipment in place to do that in the new facility. So we think that it's going to be really a place that's going to fully meet the needs of our residents and their expectations. And then we're taking what's now assisted living and creating 20 more skilled nursing beds. And what we've done with those beds is to take the large units, the alcove units that were assisted living, and created skilled nursing small apartments, so that our long-term care people that are going to be in skilled nursing for 1, 2, 3, 4 years, and there are some of those that will be there. We've got residents, our own residents, that have been in skilled nursing for 3 or 4 years, and we're trying to create, rather than like an inpatient room, we're trying to create an apartment setting. So those are the things that are going on.
Well, that's exciting, and I know that you've had great success. Your residents are happy, and you're going to be even adding more after that to allow more folks to come join the community at the village. So I congratulate you.
Thank you very much. We have about 45 people on our wait list right now, so we're excited.
It's wonderful. Thank you.
Thank you.
Up next, the number of palliative care physicians is growing. We'll talk about the benefits of this new medical specialty offers to patients. We'll be right back.
You can now watch your favorite Germantown community television shows from anywhere in the world. GHS-TV is streaming online, live 24/7. A viewing screen displays our channel just like you see on television. Simply visit our website at www.ghstv.org. So log on and enjoy hometown news from anywhere in the world, only at ghstv.org.
Every day is so wonderful, and suddenly it's hard to breathe.
Would it be okay if I sat here?
Is she serious? Whatever. New girl.
Sing away. Yes, words can't bring me down.
Reaching out. Pass it on.
So don't you bring me
A message
down.
from the Foundation for a Better Life.
Dr. Clay Jackson, Medical Director for Methodist Hospice and Palliative Care Service, joins us to talk about a type of medicine that focuses on quality of life. Clay, welcome. Glad to have you back.
Good to be back, absolutely.
So we got some questions for you. Are you ready?
Fire away.
All right. Well, we're going to start just right from the top. What is palliative care?
Palliative care is a medical specialty that provides for the comfort of patients that have severe or life-limiting illness. So these are patients that may have advanced cardiac disease or heart disease. They may have advanced lung disease. Some of them have cancer, or some patients have Alzheimer's dementia. These are some of the examples of what we mean by severe or life-limiting illness.
Okay. Well, would these patients be having curative treatment along with palliative care?
Absolutely, and that's one of the differences between palliative care and hospice. As you well know, hospice is a program that's multidisciplinary. It is designed for patients that are near the end of life and we do not feel that medically we can fix what the main problem is. For a patient receiving palliative care, we may be able to fix the problem. For instance, I've had patients that had severe heart disease who are receiving palliative care, and then they had maybe a heart surgery to correct a valve problem, and they went on to go back to routine living, even to work. And so they didn't need palliative services anymore or comfort care because we were able to fix the core illness. Another classic example of a palliative care patient that can receive curative therapy is someone who has cancer. We have many patients at West Clinic that are receiving palliative therapy as well as treatment for the cancer, and some of them fortunately are able to get rid of the cancer disease or eradicate it, and we can continue with routine life.
That's great. So how does a patient or a patient with a family go about starting palliative care?
Well, it depends on what setting that you're in. We can deliver palliative care services in a variety of care settings. In the home, there's an outpatient program with whom I work called the Aspire Company, and we have nurse practitioners and physicians visit in the homes. Palliative care can be delivered in a clinic. We have a palliative care clinic at the West Clinic as part of the Methodist umbrella. It can be delivered in the hospital or in other specialty settings. So if, for instance, you were in a hospital setting, you could ask your attending physician or your physician of record, could you get a palliative care consultation and have the palliative team see me? Most hospitals in the United States that are above 50 beds do have a palliative care service. So all of our Methodist hospitals, for instance, here in the city, have a palliative care service. If you're on an outpatient setting and you feel that palliative care might be beneficial, it's good to ask your doctor, hey, would I benefit from palliative services? And if that doctor doesn't provide it, then he or she might be able to consult a palliative specialist.
How has that knowledge amongst primary care internists grown over the last few years relative to palliative care specialists and willingness to reach out and involve them in their patients' care?
I would say I could sum it up in one word, William, it's exponentially. Palliative care is the newest medical specialty. It was recognized by the American Board of Medical Specialties just within the last decade. So there's a growing body of literature and research in how we can best help patients. For instance, even 10 years ago, we felt that sometimes palliative care was just for folks that we couldn't do anything else, so let's provide comfort only. That's a phrase that I typically don't like because comfort is not comfort only. We now know that good palliative care and good symptom relief actually can increase not only the quality of life, but the quantity of life. So there's a landmark study for patients who had lung cancer, for instance, that showed with palliative services, those patients actually survived longer than lung cancer patients who did not have that. So the knowledge base is growing, the acceptance is growing. It's an exciting field of medicine to be in because we can see dramatic improvements in patients' lives.
It seems that it would make good sense because it would take stress off of the patient, I would guess, in a lot of ways. Who do you work with to provide the care? I'm assuming there's other specialists that you work with to provide this care.
Absolutely. Hospice and palliative care are interdisciplinary by nature. In fact, in order to be a Medicare certified hospice, we're required to have the presence of physicians, nurses, social workers, chaplains, and volunteers. Those 5 disciplines have to be represented in a Medicare certified hospice, as is the Methodist Hospice. Palliative care is the mirror image of hospice in that although we provide care for a larger number of patients and a wider variety of patients for the reasons that we talked about earlier in terms of curative attempts of the illness, we still are multidisciplinary, interdisciplinary in nature. So often we have nurses that are part of the team, nurse practitioners. We also utilize chaplains and social workers for spiritual and social needs as a patient may require.
I see. As far as pain management, do you involve other specialties with that, or is that something generally the palliative care specialist is managing directly?
A palliative care specialist often does manage pain control. Pain is one of the core 8 or 9 symptoms that we do pay very close attention to. However, the view of a palliative physician is different than what a view of a pain specialist only might be. For instance, with my patients who have severe life-limiting illness, the balance between safety and efficacy is different.
Right.
I'm primarily concerned with the patient's comfort, not necessarily some of the longer-term risk of some of the medications that we use, particularly as the patient draws toward the end of the illness trajectory. An extreme example would be if I know a patient has days or weeks to live, I'm not worried if there's a side effect from medicine that may affect them 10 years down the road. Whereas a pain specialist who's treating ambulatory patients with chronic problems, these are patients that are walking in and out of clinic, they need to be much more concerned with, for instance, how medication might affect their reaction time if they're a truck driver, for instance.
Sure.
So the approach is different. Also, another thing that I might mention is there are many pain specialists who can provide interventions, such as nerve blocks and things. Most palliative physicians do not provide those services.
I see. Well, thank you. Up next, we're going to talk a little more about hospice, but I want to ask you some differences between the two, but we'll get back to that.
Thank you.
Straight ahead, we'll learn more about hospice and what it is and what it's not. We'll be right back.
Check it out.
When it gets cold, feels like the end. There's no place to go, you know I won't give in. No, I won't give in. Keep holding on, 'cause you know we'll make it through,
Wow. College already.
Yeah. We gotta go.
For all the truth that you made
I love you.
for all the joy you brought to
I love you too, Daddy.
You're the one who saw
And thanks for everything.
Gratitude. Pass it on. A message from the Foundation for a Better Life.
We're talking with Dr. Clay Jackson, Medical Director for Methodist Hospice and Palliative Care Services. We just talked about palliative care, but tell us what are some of the differences between palliative care and hospice, Clay?
Well, here's a mental image. I would consider palliative care to be a platter, and hospice is a plate on that platter. So palliative care encompasses more patients than hospice. The key difference, they're both seriously ill patients who have lots of symptom control and to some cases have some decisions to make about their care. So I say palliative care is for patients with tough symptoms and tough decisions. Should we or should we not continue this treatment, for instance? Hospice is the same set of patients, but it is a smaller subset for whom we're sure that the core illness cannot be fixed. Advanced Alzheimer's disease, stage 4 cancer in many cases, class 4 heart disease or congestive heart failure, and finally end-stage COPD or emphysema. Those are the 4 big categories of hospice patients. The core difference is in hospice, we don't feel we can fix the core problem.
Now, we know these things, but many times we wait longer, and from what I understand, and I know just probably enough to be dangerous, but one of the challenges we have with truly getting the most from hospice care is getting involved with hospice care soon enough, is we wait too long. How do we know when it's really, and how as lay folks and with our loved ones know when it's the right time for hospice care?
I think any time that the question crosses your mind, it's great to ask the attending physician, whether that's on an inpatient basis or an outpatient basis. When we think about the question, it's a good time to ask. You're exactly right. In this country, the average hospice patient stays in hospice 14 days. That's just way too short for us to have time not only to control the physical symptoms, but to get the social support for the family and also the spiritual support for the family and patient that we need to do. So asking the question earlier is a great thing. One of my favorite consults that I get is a patient who's actually too early. Mm-hmm. And I don't chastise that doctor for saying, why'd you send him? I'm so happy to get that too early consult because I can meet a patient, meet a family and say, hey, here's my card, we'll be here if you get sicker. You know, let's just talk about this, and then if the patient needs us later, we're still gonna be there.
Are you seeing any improvement with this challenge?
I am. I think our country is changing, and it's not just about healthcare reform and some of the things about ACA or the Affordable Care Act. I think there's a growing realization that technology is not the answer to our most serious healthcare problems, that we not need to follow what I call the technological imperative. Let's build a bigger, taller building, or let's build a bigger machine. But we need to follow the therapeutic imperative, and that is what we're doing actually helping the patient? We're thinking of ways that we want to die. We're realizing that life is a terminal condition and that we can choose how we want to die, whether that's hooked up to a lot of machines in a very highly technical environment or whether it's in a more personal environment. And so I think those fundamental changes are shifting the landscape toward a smarter way of caring for patients.
Well, in some ways, I think the technology has made the challenge more difficult for folks.
I think it has, but I use a lot of great technology in my practice.
No doubt.
So I can't bash technology. I have great medications. I have great delivery systems where I can look at a patient dead in the eye and say, you will not die in pain. You will not die with anxiety. You will not die with nausea. So I thank goodness for that technology. But Absolutely. I also realize that I need to control it in the therapeutic interchange rather than the technology controlling me and the patient. We need to remain in charge as clinicians and patients.
Well put. Most of us, we don't like to talk about dying. It's kind of a taboo topic, but should we be more comfortable talking about death?
Well, as we sit here in studio today, we're during the holiday season. It's a time when families get together, and this may sound like a strange time to talk about death because we're celebrating life during this time, no matter what our cultural and religious heritage may be. However, I think it's a wonderful gift to talk about with our families what we want to happen, how we want our wishes to be expressed if we're not able to talk about those things if we become seriously ill. I think one of the most difficult challenges that I have, and you could probably attest to this in your role in administration in a hospital, is when we get to the end of life and the patient's wishes are unknown. And the family has to do so much guesswork and they just don't know.
Yeah.
We often see multiple sibling families have a great deal of conflict around the end of life.
Right.
It's very tragic at the bedside for these hushed conversations and conflict-ridden conversations to be in the hallway. There's absolutely no need for it.
Right.
If we as persons will do for our children just a simple favor of letting them know what we want, can save a lot of conflict during a very difficult time that's going to be emotionally riven enough for them.
Yes.
Why place the additional burden on them of trying to guess what we want? It's not a way to do that.
I think that's great. You've already talked about the ability to manage pain, and that's a huge issue, to make folks comfortable at the end of life and deal with anxiety. Not wanting to have our loved ones suffer is a big deal. Is there any more that you'd like to be able to say about that?
Oh, it's just wide open. You know, in palliative consults and hospice care, I often deal with depression. I deal with anxiety, agitation, spiritual distress, and we rely on our chaplain colleagues to help us a great deal with spiritual distress around dying, or, you know, what is the meaning of my life as people begin to construct their sort of memories for the next generation as they realize that time is short. There are just a wide variety of things that we help people take care of. I think one of the chief things that I've learned over the last few years is that many patients want to maintain as much function as possible. So we have conversations about, is it safe for you to drive? Is it safe, you know, is it safe for you to walk and get out and go to the mailbox? So trying to help patients balance not only symptom control, but functionality at end of life is where we earn our chops, so to speak.
To have a good end.
Absolutely.
A good life and a good end.
Absolutely.
Thank you for being here.
Appreciate it, William. Thanks so much.
That wraps up our show for today. I hope that living well will help you and your family lead healthy lives. Thanks for watching. I'll see you next time.